Morning. Yeah.
Good morning, everyone. I'm Robert Dempsey, and on behalf of the Foundation for International Education Neurological Surgery, I want to welcome everyone to our virtual visiting professor program. Quarterly, we meet and have some of the great minds of the world discuss neurosurgical topics of interest. This is part of our postgraduate program for FEENS, with heavy involvement of our Young Neurosurgeons program and our alumni of our fellowship programs. So there's a big involvement there. I want to particularly mention Dr. Jack Rock, who is in charge of coordinating the virtual visiting professor program, because it really marks an extension of the work of FEENS from simply developing residency training programs, but also continuing the education as we continue not only the fellowship programs, the residency programs, but postgraduate education at all levels. We're very delighted to have an excellent presentation today by Dr. Thango of South Africa, who is a recognized expert in pediatric neurosurgery and trauma and critical care. We'll talk about the global impact of head injury and trauma. Our moderator will be Dr. Tran, speaking to us from Ho Chi Minh City, continuing the very international look of FEENS. Dr. Tran is one of our alumni of our fellowship programs, and we very much want to have the alumni of the programs involved in moderating. So without further ado, I thank you all for being present. And Dr. Tran, would you please introduce our speaker? Thank you.
Thank you, Dr. Dempsey. And good morning or good evening to all of you joining us from around the world. My name is Tran. I am a neurosurgeon at the Department of Neurosurgery, Children's Hospital 1, a lecturer of University of Medicine and Pharmacy at Ho Chi Minh City. It's my great honor to introduce Dr. Covell Tango. Dr. Tango is a leading pediatric neurosurgeon and lecturer in neurosurgery at the University of Cape Town. She also served as researcher at the UCT Neuroscience Institute on the Africa Brain Trial Initiative, where her work focuses on neurocritical care, antibiotic pharmacokinetic insurance with brain infection, research education, and capacity building across the continent. She is a chair of the Young Africa Neurosurgeon Forum, an organization that has played a key role in advancing research and educational initiatives throughout Africa. In addition, Dr. Tango is a research co-leader of WSNS Global Neurosurgery Committee and the WSNS Young Neurosurgeon Forum. Today, Dr. Tango will present on traumatic brain injury in a global context. This presentation will offer a comprehensive perspective on how TBI is managed across diverse healthcare systems and the steps we can take to improve outcomes globally. Please join me in welcoming Dr. Covell Tango.
Thank you so much, Dr. Tran. I'm just going to share my slide. Okay. So good morning, good afternoon, or good evening, depending which part of the world you're joining us from. I'd like to thank you, Dr. Tran, for the introduction. I'd like to thank Prof. Dempsey and the whole FEENS team for the invitation. So today I'll be talking about the global context of traumatic brain injuries. My focus will be a bit more on pediatric injuries, given I'm a pediatric neurosurgeon. So as we go through this slide, we'll be looking at the background, looking at where we are globally in terms of brain injuries, what the data says, what's the context and reality on the ground, the barriers that in different regions patients face when accessing care. And then at the end, we'll just do a case study of how excellence can be nestled within sub-Saharan Africa and how we should all work as a global community to tackle this disease burden. So when we look at traumatic brain injuries, WHO projected global death rates are projected here on the screen. And one of the things that we can appreciate is that the communicable diseases and some of the non-communicable diseases like cancer are showing a downward trend given to the investment in extensive research and public health campaigns by our physicians and public health colleagues. But if you just take a bit of a look closer, you'll see that road injury trauma is on the increase. And a huge portion of this, up to a third, are traumatic brain injuries. So traumatic brain injuries are a serious major public health concern. They have significant socioeconomic impacts on public healthcare systems, and it takes healthy individuals who are contributing to societies and makes a lot of them a morbidity and a strain on health systems. The healthcare cost baseline involved in treating this patient group is high from injury up to even 4 years post the injury. And what you can appreciate is the highest TBI is from road traffic accidents is found within Africa and Southeast Asia. So these are areas that experience the highest burden. But as many know, we have a paucity of the neurosurgical workforce. So now when we look at the data and what the data is showing us, one can't help but notice that it is skewed. So incidence measures the rate at which new cases are appearing in a population versus prevalence, which is the overall burden of the disease or condition in the population at a particular time. So in public health, when it comes to resource allocation, knowing the incidence is important because it allows healthcare systems to target at-risk populations with interventions to prevent new cases and mitigate the effects of the disease. So TBI currently within LMICs is a silent pandemic because the data remains uncaptured. So currently within literature, it says that the highest incidence is found within America, US, and Canada, and Africa has a lower incidence. When we take it closer to pediatric TBI, the lowest incidences are found within Sweden, the highest are found within Australia. And then when we look at age standardized data, so age standardized data is a statistical measure that removes the effects of the different age distributions when comparing disease rates, because we know there's a bit of bias because the global south has higher number of children than the global north. Even when we remove this bias, there's still a higher incidence of TBI in literature within Europe, at least South Asia is featuring, but a lot of sub-Saharan Africa and Africa is showing a low incidence. And as I go through this slides, I'll show you why this is a concern and how we as a community should work together to address this. So data does not give an accurate picture of the reality on the ground, and this is mostly because of the research inequity. So we know that the risk of childhood injury is higher in areas where there's material deprivation and low socioeconomic status. And this picture depicts that quite nicely. So to the left are children playing on what they conceive as a playground, which is a road, in a semi-urban area within South Africa. These areas are known as townships. And you can see that in more well-resourced areas, there's often protected playgrounds. And one must remember that in different areas of the world, similar contexts do exist based on socioeconomic disparities. So it can't be that a region with the highest amount of children and the highest risk of injury is recording the lowest incidence of traumatic brain injuries. So when we look closer, this is just a case example of a wonderful study which was done in South Africa by our trauma surgeons, which are in Johannesburg. So just to give context, South Africa is an upper middle income country. We're Africa's largest economy, but we're also known as one of the most unequal societies in the world. 84% of our population relies on public health care. And this study was done by one of the largest trauma centers within South Africa, which are nestled in a semi-urban township in Johannesburg, Soweto. And in a system where there is access to surgeons and who are ready to treat, the obstacle here is access to pre-hospital care. So in the study, they found 47% of patients after trauma arrived in private vehicles. That means people picked up their relatives, threw them in the back of the car and rushed them into theater. And one can appreciate when they look, to hospital, one can appreciate when they look at this picture that extracting an injured patient from an informal urban settlement is near impossible. There's no structured roads. Google Maps doesn't work there. So our national healthcare plan aims to ensure that at least basic life support is available and within 20 minutes to where you live. But most of the areas of care within these semi-urban areas close after hours, and we know that's when the injury happens. The average pre-hospital time is 2 hours, and we know in trauma, we deal with that golden hour. And once you pass that hour, the risk of mortality substantially increases. And with 32% of the road traffic accident mortalities had an injury severity score of 30. That means these were potential survivors who didn't win the race against time. And this is an example of just one barrier. There's areas where there's barriers to care because of finances, where patients have to pay to see the doctor, they have to pay for the antibiotic, they have to pay for any medication that is given to their relative. So the next question is why pediatric TBI is important. And this we'll be able to see in the next slides when we look at examples of population pyramids. So this is also just another case example of South Africa. Currently, South Africa has the highest young youth unemployment rate. And when you look at this population pyramid, you can see that we were warned about this 15 years ago, and we had all this time to ensure that we had workspaces to absorb the large workforce that we have today. But unfortunately, when you don't prepare and structures are not in place, you are left in a situation of crisis. And when we look at the pediatric population globally, currently in 2025, so for this slide, the definition of pediatrics is age less than 14 years. So if you look in Africa, currently the pediatric population is 281 million, and the largest portion of this is between the ages of 0 and 4 years, 100 million. When you look at Asia, Asia currently houses the largest pediatric population, 560 million, and their highest numbers are nestled between the 5 to 9, which is 190 million, and 10 to 14, a further 190 million. When we look at Europe, the pediatric population is 59 million, and their highest numbers are found within this age groups, and we're looking at about 21 million in each. So what you can appreciate here is Africa has a triangular expansive shape, which shows that we have high birth rates and a rapidly growing population. So one can foresee that in our region, we are headed into serious trouble. So this is a scary statistic for any pediatric neurosurgeon or anyone who has an interest in global health. 1 in every 4 children will be from sub-Saharan Africa in 2050. Whether we like it or not, the future of pediatric neurosurgery will be in sub-Saharan Africa because we will have the largest numbers. That means we would hopefully need to have resources to train future pediatric neurosurgeons, and we'd need to have workforces together with Asia that are able to have guidelines that are adequate and reflect our environment. The question is, are we ready, or are we even taking steps to address this future problem? And when one looks at causes of deaths in children, you can see that road traffic accidents are 7.9% between the ages of 5 and 19. Those are higher than TB and malaria. But as you look closer, you notice that there are potential injuries that are not being captured. And hence, that's why pediatric TBI should be viewed as a silent pandemic, because we are not capturing the numbers. And that was very well reflected in the slide that I showed on the current incidence of TBI. And that means healthcare systems are not gearing resources to deal with the situation because it remains silent and unrecorded. So on a positive note, a team within neurosurgery has been working very, very hard to get TBI as a notifiable condition. So why this is important is that notifiable diseases are of public health importance, and they require systematic collection, analysis, and use of data to detect and act against threats to the public. And the overall aim of this is to enable a rapid public health response and appropriate resource allocations. So currently, when healthcare directors look at incidence rates in their regions, especially in sub-Saharan Africa, to them, TBI is not an issue. They view HIV and malaria and infectious diseases as an issue because our data remains unrecorded, and this is a sign, unfortunately, of research inequity. And the positive of being a global community is sometimes we need to address the elephant in the room and start discussing difficult topics so we can all move forward in terms of making systematic change. So this is a lovely article done by a team from Global Neurosurgery. And the reason I choose Global Neurosurgery in terms of research inequity is that global surgery is a field that improves access to safe and timely surgery, especially to vulnerable populations. A lot of them reside within the LMIC and LICs. I need to remind people that vulnerable populations are also found within HICs. So it's just a large number happens to be in LMICs. So what is central to it is health equity. That means regardless of your age, gender, socio-economic status, if you need urgent surgical care, you should be able to access it in a timely manner. So even within a discipline that is focused in addressing high equity, specifically within NICs, there is evidence of research inequity and unfortunately what's helicopter research. So 55% of first and last authors are from the US. 28 publications had no LMIC author. Almost half only had one. So for those who don't know what helicopter research is, it's a research practice where scientists, sometimes mostly from HIC countries, conduct studies in low-income regions, collect data, and then depart without adequate involvement of the local scientists or community members. This tends to leave little or no tangible benefit for the host countries. And to address this, there's been a Cape Town statement fostering research integrity, and I'd strongly encourage members in the audience to read this because they have 20 recommendations in terms of how to mitigate this. And this isn't only in surgery and neurosurgery, this problem is rife within public health as a whole. So LMICs house the world's largest pediatric population, have the lowest neurosurgical workforce. So the question is, when do we let our patients and our surgical workforce tell the stories of their lived experiences on the ground? But the future is not too bleak. So there's this concept of Africa Rising, which came around in around 2011 to explain the rapid economic growth that was happening specifically within sub-Saharan Africa from 2011 to date. And we know that when there's an economic growth, it has a good correlation with improved health outcomes, because the higher your GDP is per capita, it's usually associated with a lower infant mortality, more government spending on healthcare. Not always the case, but should be. Technological advances and technology and improved healthcare structures are critical to what we do as neurosurgeons, because our subspecialty is expensive and needs established healthcare structures to function. So after all of this, I just want to use our team as a case study just to explain that even within sub-Saharan Africa, there are many institutions like us that are nestled within the region and which are aimed at having excellence and providing quality care to children. So as mentioned before, I'm a researcher within the African Brainchild Initiative, which is led by Professor Figaji, who is the head of clinical unit for pediatrics at Red Cross Children's Hospital, but also the incoming ISPN president. So we're a team of neurosurgeons, medical doctors, researchers, nurses, aimed at understanding how trauma and infection affects the developing brain. We work for a government public health sector. So that means children are treated regardless of their background with no cost. Our focus is transitional research. That means we take basic research from bench to bedside and use it to benefit our patient population. So our center is the referral center for pediatric TBIs within the Western Cape. So when children arrive, they get what's called multimodality monitoring, which involves having an ICP monitor, brain tissue oxygenation, continuous EEG monitoring, and where appropriate, cerebral microdialysis catheter. For those who don't know what a microdialysis catheter is, it's a catheter that is a small catheter, which is a semi-permeable membrane, which we enter into the interstitial tissue, preferably into white tissue, and it's able to collect metabolite data and drug information. And how it helps, it gives us a real-time assessment of the pathological process of traumatic brain injuries. And all of this gets set up by the patient's bedside and allows us to detect and treat early signs of secondary brain injury. A reminder that this is in a public institute funded by government. We are also fortunate to have a nursing staff dedicated to looking after our patients over 24 hours. So what have we been able to achieve with this system? We've been able to have one of the largest TBI databases looking at high frequency data within the pediatric population. And the next few slides will just be a bit of the research which our team is doing within severe traumatic brain injuries. So one of the things we're looking at, and we've looked at, is the relationship that pressure reactivity index has with outcome and mortality after traumatic brain injuries. So those people who don't write PRXs, it quantifies cerebral autoregulation by measuring a Pearson correlation between spontaneous slow wave fluctuations of ICP and your arterial blood pressure. So if your PRX value is closer to -1, it indicates that you most likely have intact autoregulation. When the value drifts up closer to 1, it signifies impaired autoregulation. And we've shown that this has higher risk of poor outcomes in children. So as you can see, the survivors tended to have their PRX closer to the -1, but when it gets higher, it's associated with the higher mortality. What we've also been able to see is that there's a close correlation of PRX with CPP. So the lower your CPP, the more chances are that your PRX is higher. We've also been able to take a look at the metabolites themselves, and we've been able to show that the lesion progression on head CT has a strong correlation with glycerol. So glycerol is a product that gets released by your brain during the cell membrane breakdown, and the relationship is strongest, especially when lesions are increased by 30%, and this is what we've been able to find. And this physiologically makes sense. Also, the LP ratio, once it's above 25, we know that you're now being pushed into anaerobic metabolism. And we've been able to show the close relationship that LP ratio has with brain oxygenation. And I think physiologically, this is explainable. And what's exciting is also it's given us an opportunity to assess how drugs work within the closed central nervous system. So this is an example of analgesia, but we're also looking at antibiotics in TB and CNS infections. So we know that morphine and angiosedation plays a critical role in the supportive therapy of traumatic brain injuries, but little is known about how much of that drug reaches the brain. So with a team of researchers, we've been able to look at a physiologically based PK modeling, which allows us to predict morphine concentrations in the injured brain during severe TBIs, with the hope that such model could be applied also in a non-TBI context. Along with that is advocacy and patient education. So within the ABC group, Professor Rolwink has worked really, really hard with us on the advocacy aspect. And we run a Brain Awareness Week where young scholars are brought in to be taught about how to protect their developing brain. In our patient cohort, we've seen a large portion of our TBIs are due to MVAs and pedestrian vehicle accidents, but the MVA population group are unrestrained pedestrians. So what we've done is a Be Quick to Click campaign where we've been raising money so that mothers and fathers can get access to car seats for their children so they can also be quick to click. So this is an example of health equity in action. And just to remind you, we're not the only center on the continent doing this. There's pediatric excellence centers in Uganda, Ethiopia, and Cairo in Egypt, and many others. But it's showing that there is a beginning in moving towards addressing the future burden that we'll be facing in sub-Saharan Africa. And that sub-Saharan Africa and Africa as a whole does have the structure to train pediatric neurosurgeons for the global workforce. So future directions for global pediatric TBI. It's realizing that we both need each other. LMIC needs HIC. HIC needs LMIC. We both need to work together to tackle the burden that we currently have and the one that is coming in the future. We need to have accurate incidence and prevalence rates within the LMIC and LIC environment, because we've just seen in the previous slides the importance of this in terms of allocation of resources within public healthcare systems. We need centers of excellence in areas that have the largest pediatric population, which is currently Asia and Africa. We need to increase our neurosurgical workforce and our allied health workforce, because when managing a pediatric traumatic brain injury or any traumatic brain injury, it involves you as the neurosurgeon, the critical care team, but also your allied healthcare workers have a significant impact on the outcome of the patient, your physios, your occupational therapists, your social workers. We need bi-directional learning and guidelines with context of the environments that we're in. So I'd like to say Ngiyabonga, which in Zulu, which is my home language, says thank you. And as I've mentioned, I come from the University of Cape Town. And I also just want to acknowledge my mentors, because I think as you progress in the journey of being an academic neurosurgeon, it does not happen overnight, and it needs investments of a whole society. So for my love for research and pediatrics has been heavily influenced by Professor Figaji, and also my love for global surgery and improving the neurosurgical workforce within Africa has been heavily influenced by my head of department and head of the Neuroscience Institute, Professor Figaji. So all of the slides shows that how mentorship plays a role, and this is the importance of programs such as FEENS, because the next generation of neurosurgeons relies on standing on the shoulders of giants. Thank you very much. And Dr. Tran, if Professor Figaji is one of the participants, I would appreciate if he has a few words to say, but if he's not around, that's fine. Thank you, everyone.
I do not see Dr. Figaji. I do see Professor Albright and Professor Kitia, if they have.
Oh, okay. They're also welcome to comment, because they've also done a lot of work in the region. But thank you very much,
Quite a lot
everyone.
of work there. Dr. Albright, do you have a question?
Can you hear me?
Yes, indeed.
No, I don't, but I applaud this lecture. Her phrase, helicopter research, I'd never heard that before, and it is so paradigmatic for what goes on for research in so much of South Africa. I also applaud the research, the lab research, well, the clinical research, I mean, in the ICU, the way all of the things they are measuring intracranially and trying to determine which ones correlate with outcomes. So no questions, but a great applause. And I'd like to know if this is being recorded so that I could forward her lecture to a couple of neurosurgeons in Kajabi.
Absolutely, Leland. The entire series is recorded and available for public use. And usually, as I've said, we have dozens in real time and thousands over the months that follow these lectures.
Thank you.
Excellent.
If I could just say a word to Professor Albright, one has to acknowledge the significant impact you've had on pediatric neurosurgery within Africa and the powerhouse that's been established within Uganda in terms of pediatric neurosurgery. So thank you for your comments, and great to know that you're online. Thank you.
That's very good. And
Thank you,
Dr. Tran,
Thank
I
you.
see Dr. Kitia is there. Dr. Kitia, do you have any thoughts from your work in Uganda?
Thank you. Thank you very much, Dr. Dempsey, for inviting me, and Dr. Songa for presenting this work you have done in Cape Town. You are very right about pediatric TBI, that we have high incidences, but we haven't reported this, and this reflects to what support we can get from the rest of the world. Because if we don't show what we have, then nobody's going to know what's happening around. And yet we have quite high prevalences of TBI. and that at least for us, we have found that the biggest incidence is between 0 and 4 years. And we have found that such a picture occurs because many of our children are pedestrians, and they are not attended to when they are going to school or when they're coming back from school. And so once they're not attended to, then the instances are going to be high. And that the commonest cause is still, like you said, road traffic accident. And that the instances go up until the age of 15 years, and then until the age of 5 to 7 to 10 years, then it goes down and then climbs up again after the age of 15 years, because at that time, they are already maturing into adults, and they are trying actually to drive motorcycles, because the biggest cause of our problems here in Uganda are actually motorcycles. So you are right in what you have said, but for us, we have not gone up to that detailed monitoring like you have shown us, and that's why we need actually one, excellent programs, and two, support from the high-income countries, so that our students, our young students, can come to those centers and pick this knowledge, this information, and bring it back to us. I thank you very much.
And one of the people who has done that is Dr. Tran, who has gone to the higher income countries, learned more, brought back. Do you have questions, Dr. Tran?
Yeah, thank you, Dr. Dempsey. Thank you very much, Dr. Tango, for a very amazing presentation, and inspires for doing research. In Vietnam, the pediatric neurosurgery is just at the beginning, and now we just focus on some clinical work. But here I can learn you can do a lot of basic research on TBI. So could you give us some advice at the beginning of doing research in basic research about the TBI, or in a low-income country with a lack of resources? Thank you.
Thank you. That's a very good question, because pediatric neurosurgery as a subspecialty is also still in its infancy within sub-Saharan Africa. A lot of neurosurgeons do a lot of pediatric cases. So they are pediatric neurosurgeons, even though without subspecialty training. And I'm sure in your region, it's similar, where a large portion will treat children. So the biggest thing is not to underestimate demographic data, because that's the language that public health care practitioners understand. And that's why also supporting initiatives in terms of working together to get TBI as a notifiable disease is important, because once it becomes a notifiable disease, your country's healthcare systems has to have measures in place to capture the data. And then you'd be able to quantify the numbers. But while we're starting with that, demographic data is what we use to motivate for resources. So even locally, just starting to have a database on your pediatric patients, and then later on being able to approach your hospital management or your local health officials and be like, 40% of our patients are having this type of injury. These are the risk factors we've seen. These are the interventions we propose. And this is something our physician colleagues have done extensively well. And that's why they have a lot of funding into their communicable diseases, is because they've been able to show the numbers. So the first point is just start by collecting the data, and then all of us collaboratively working together to raise awareness and hopefully get it as a notifiable disease. Thanks.
Thank you. Yeah.
Dr. Thango, could I ask a little bit? I really applaud the work you're doing at every level: prevention, acute intervention, and I will talk a little bit about the repair of the injured brain. But our impact should never be underestimated. In Dr. Phan's home country, the advocacy which led to helmets for motor scooters has significantly decreased head injury, and that's neurosurgeons advocating. I'm very fascinated by your work, which combines the basic science with the clinical science. And as you say, it's possible if you can demonstrate to the people in power the importance. But I think you're looking at a gem of an idea for repair of the injured brain. As you look at your idea of looking at brain proteins, have you looked at some of those? I have a particular interest in one called galactin, which is important for repair of the brain. I've been trying to follow that with the injured brain as the look for something that we would enhance the healing. Could you say a little bit about our role in the repair of the injured brain, especially the pediatric?
Amazing. Yes, amazing. And that's quite an interesting aspect. And we've got people that are specifically interested in the genomics of, pediatric TBI and rehabilitating the pediatric brain. So for myself, right now, that's not my subspecialty interest, but our team has started looking at that. And the cohort that we're currently looking at within that is actually the minor and moderate TBI group, because we're able to get bigger numbers, because unlike you guys in the US, we're still trying to establish gene databases and genomic databases in our region. So the numbers are important. So there is a team within our network looking at that and doing work on that. And maybe afterwards, Prof. Dempsey, I'll send you an email and give you their contact, because they would be able to better represent the work that they are doing.
I'd be thrilled to help, including the genomics, of which we have both genomic and epigenomic changes there, which I think that collaboration would be wonderful.
Absolutely. I will reach out to you.
Thank you. Jack, do you have any thoughts?
I was wondering about when Dr. Thango was talking at the beginning about the townships and how far, what kind, you were saying in most areas in South Africa, you have access to high quality trauma care within 2 hours, or were you saying you need to have it?
So that study showed that we have it within 2 hours, but we don't think it's enough. And it's also a discrepancy. So the more urban the area is, the better quality they receive, because these semi-urban township areas is where the poorest live. There's lack of road infrastructure. So they are the ones that tend to have the most delay in getting trauma care within South Africa, due to the complexities of reaching the accident scene. And when I mentioned the fact, one of the points I mentioned is that our government aims to have emergency care within 20 minutes of where people live. For them, emergency care is preventative infectious diseases, because they haven't realized the burden of trauma within our communities. So that means, yes, people can access clinics within 20 minutes from where they live to get their TB, HIV medication, hypertensive medication. But when it comes to trauma, the after-hour care within those vulnerable populations is limited, because that clinic will close at 4. And when you have trauma, you have a longer distance to get to tertiary or intermediate hospitals where the specialists are that deal with trauma. So even amongst our concepts, our context, is very important for us to raise awareness about TBI, because our government is mainly focused on infectious diseases at the moment.
I see. I'm wondering if at some point you probably read about the infrared kind of technical things that help. And I know that the Birmingham group, and I think Dr. Haglin and a couple others, we almost started something like that in Myanmar before the coup. And that is not perfect, but at least when there's no CAT scan in the areas outside the main cities, it really represents something that can help with a differential diagnosis of, even after a head injury, whether there is a hematoma, and follow up and who needs to get transferred. The way you're shaking your head, I think you know about it.
Yes, no, it's fantastic, and very excited for TBI or any bleeds in the brain. So currently we're doing a pilot study because we always need to motivate and show the relevance of it to be expanded beyond. So we've got a pilot test study at the moment where we're trying to pick up the predictive value of it. So we currently do have infrared scanners, and these were ideas we got from, centers such as yourselves and others that have been looking into this. And hopefully, potentially, it could be an avenue. But as usual with our healthcare department, they first want to see, does it work in our context before it becomes something that can be used in a wider site? It would go a long way in limiting a wastage of resources and hopefully being able to pick who needs a scan urgently peripherally versus everyone having to come for normal scans sometimes and be sent back. So yes, thank you. That's relevant.
I thank you for joining us today. That's it was a very, very interesting presentation you gave.
It's a fascinating topic. I would like to follow up, if I could, on your emphasis on this idea of making sure that our colleagues in government and economy understand the importance of this problem. And the fact that us as neurosurgeons can do a lot about that because we are very influential in our own homeland. And presently, you mentioned and showed the picture of Dr. Tariq Khan and the work about making head injury a notifiable injury so that worldwide would be something that's recorded so we'd understand the full extent. And this is the issue that neurosurgery would be bringing to the World Health Organization this session, just as in the past, folate supplementation has been successfully brought by neurosurgery. So the most important message is we all can help by advocating with our own ministers of health in our own countries so that this is met from the ground up with a swell of enthusiasm, that we can change the idea, because children are being injured daily, minutely, worldwide, and we need to mobilize our resources toward that important and lifelong effects. So thank you.
Yes, absolutely. And it speaks to collaboration and the strength in collaboration within neurosurgery and, Professor Tariq Khan and the whole team and everyone that's involved in that. It's amazing how a concept, when we all work together and use the influence we have to project a message, can go a long way. And hopefully also it gives the younger neurosurgeons, because in Africa we have young neurosurgeons entering workforces, being single neurosurgeons, being isolated. But if they can see the role of advocacy and be supported, such as what FEENS does and the Global Neurosurgery Group, it goes a long way in empowering them to realize that they can do a difference today for their patients by advocating for resources. And it's something that's capable and possible to do with the support of the global network. Yeah.
You've allowed us to think beyond ourselves. We are often so busy looking at the patient in front of us, but we have an ability to influence a next generation of neurosurgeons and a present society that I think is very responsive when they know achievable goals that can help people, especially children. Dr. Tran, do you have other questions from the audience or yourself?
Yeah. I have one question from the audience. One question is asked about decompressive craniotomy in children. So, where do you preserve the bone flap in children and the fine in your setup?
Okay, that's a fantastic question. So just as a disclaimer, we tend to have a lower decompression rate in pediatrics compared to other centers. Our decompression rate is 12% because mostly our population that has those severe trauma injuries are 0 to 4, 5 age group. When we store in a bone fridge. And what happens is we try put the bone back within 2 weeks of admission. So we try to do it in the same admission. And what happens is it's stored in a bone fridge. There's swabs that get done. So we do a swab before we place the bone so that if we pick up anything, if there is an infection, we know what organism we're treating. But there are other centers that have put the bone flap in the abdomen. So it really depends on your context because sterility is important. So maybe in your context, you might find it. And children, remember, they have very small abdominal fats. Maybe when they're a bit older, you might be able to. But we have a specific bone fridge, and it can work from anything from a -20 to a -80. So yeah, we use a bone fridge for that. Thank you.
Thank you. And we have another question. So from Dr. Ann Pry, which data do you use, Dr. Thango?
Which
database? Yeah.
Which database? So we have a closed database that our university gives. So a lot of our data gets stored on a REDCap and a secure data line base that's associated with the university, which we always have to pull a lot of ethics for. So it's currently a closed database in terms of that it's localized to our institution. When there are multi-center studies in the past, Prof. Figaji has then had ethics consent to widen, and we share data within the community, but we've got a closed database that is run on university service that we have access to, but we don't have a international or a national TBI database yet.
Yeah, thank you. And we have another questions from the audience, from Dr. Nathan Thango. Regarding to helicopter research, what are the best approaches you as an individual are putting into mitigate this, as it clear that the lack of data from the LMIS worsening the situations in the policy may not incorporate this? And the second is at your center, what approach is used to use as post-hospital follow-up for pediatric TBI cases?
Oh, lovely. So the first question in terms of helicopter research is continentally, as we've been looking at doing research education under CONS, and with the young African neurosurgeons, we've been running research courses, just alerting people and trying to encourage the environment of research on the continent. So people are aware and educated and realize the opportunities in terms of researching your population group and what you can do with that data. And to encourage that from within our organization, continental organization has been offering quite a number of scholarships for young neurosurgeons that are doing research to get them opportunities to interact with international colleagues and opportunities to attend international congresses. And then the next point is open communications. And I think an example of a success story where there's strong collaborations is the story of Uganda. But that has taken years of investment into that region. And I think the most important thing is all of us being aware that it is an entity, and for journals, firstly, to be able to call it out and feedback to authors if authors are having research on an area where none of the local neurosurgeons are involved. There needs to be questions of why and how to mitigate and get them involved. So it's a very complex, and I'm very new, so I'm very interested to hear what the older senior colleagues say. But I think it's a multi-layered where it's education on research, collaborations, equitable collaborations, and then from a senior level at the journal level where it's highlighted as a concern, and when it occurs, it's investigated to see the reasons why. In terms of follow-up of patients is very difficult within Africa. We invest a lot of efforts in terms of following our patients. So a lot of the time, the severe traumatic brain injuries will go to a rehabilitation hospital, sometimes for 3, even up to 6 months, which is dedicated and has OT physios that treats the patients in the post-injury phase. We also involve our social workers. So when patients don't come to follow up, community social workers then trace the patients and the caregivers and give assistance to bring them in. And also there are temporary and sometimes, if needed, permanent disability grants. So this allows the caregivers to have money to bring the patient in. So that's why when the social worker goes into the community, they need to investigate whether the funds are being appropriately used. Why can't the mom not afford to bring the child into hospital? Because she is getting a grant specifically to cover some of these aspects. But we know often that a lot of our patients get lost into the system because they can't afford to come for follow-up care. So there needs to be structures in place to support them to be able to access and come back into the care system. Thanks. I don't know if any of the team has comments on the helicopter research part.
Can I ask one question? One more question. Can you FEENS is a pretty wide-ranging organization, and Dr. Dempsey's been involved for a long time. You know him well. What can you tell us that the FEENS organization could potentially be able to do to help you with the issues that you face?
So FEENS is already doing an excellent job in terms of training, which is very important because from the first place, we need to have the workforce. And even within our units, people have had scholarships to help complete their training in neurosurgery. Because what happens a lot of times is when trainees come from other African countries, they need to have support from their health systems, which they may initially have, but then that support might run dry during their training because our health department, unfortunately, does not pay them. They get trained for free, but they don't get paid. So those collaborative research, those entities of supporting training within Sub-Saharan Africa is important, and local training. And then also with people that have interest in, in vascular or, endovascular techniques, then having the opportunity to do fellowships and see what's out there and take it back to home has been great. So I'm not trying to praise, but I've actually seen the influence of your organization, and I think the strongest strength it has is in supplementing training and subspecialty training, and there is evidence of that on the ground. So there wouldn't be anything more I'd add, because they're an example of equitable collaborations, and I've seen how they've come in times of need to help people finish their training. So at this point, I have nothing additional to add, because you guys are already playing such a substantial role that certain healthcare sectors are not able to at this point. I hope that answers it.
It's
Yes.
very kind of you. I would like to talk a little bit about the helicopter research topic and the follow-up topic. One thing about being old is I've learned to listen a lot. And I think the attitude of people is that this is a collaboration, and it's not my research, it's really the research of the people involved. I can perhaps help them, but it's theirs. And my goal is for them to be in charge and take it over. I learned from Ben Wharf, who was my partner many years ago in Kentucky, that one of the ways to enhance not only that aspect, but also the follow-up is something that he did, and I've done actually with Indigenous people in the United States. I'm presently doing a stroke prevention program with Native Americans, and our follow-up was poor until I hired tribal coaches to do the follow-up. I've never seen a patient stop smoking or lose weight because the doctor said so. Only when the patient decides, and that is reinforced by their peers. When we hired the tribal coaches to reinforce the message, to be sure about the follow-up, it doubled, just doubled in follow-up for all ages. So I think that this is a matter of understanding that the ownership of both the issue and the solutions is local. And we are invited, and we listen, and then we persist, be present. These are the components that I think would change that. And I really like the fact that you encourage the journals to police that and to be able to say, well, what is this? You know, you're looking from afar. What about the people who are there every day? And that's probably the most important lesson I heard from you today, and I applaud that.
Thank you. Absolutely. Understanding local context, and the positive news is the younger generation of neurosurgeons on the continent are more empowered in terms of wanting to stay in their local context and wanting to make a systematic change. There is the effects of brain drain in certain areas. And right now, our CONS organization is mapping the neurosurgical workforce within Africa and looking at training centers. It's a bit started off the idea by the work that Professor Gail Rousseau and our team did, looking at surgical structures within Africa and seeing how training locally tends to mitigate the brain drain. So the future is bright. The young neurosurgeons are engaged. It's about supporting them so they're not overwhelmed by the environment that they face. So that's in the positive, that there's a receptive generation that's keen to work together and be collaborative with others.
Just wonderful. Dr. Tran, do you have any closing remarks that you'd like to make? Or Dr. Thango, we really appreciate so very much not only your comments, but your lifelong interaction here and the involvement of the others. Dr. Tran, would you like to give us a wrap up, please?
Yeah, thank you, Dr. Dempsey. Thank you, Dr. Tango, for amazing presentation. Yeah, you inspire us a lot at the young neurosurgeon for doing with our condition in a developing country to enhance the research and treatment here. Okay, thank you very much. Yeah.
Thank you, everyone.
Thank you.
Dr. Tran, there was just one more question. I don't know if you saw that in the Q&A.
Okay, let me check again.
There's a question about growing bone fracture in children and when would surgical intervention be needed? This is from an early career resident asking.
Okay, thank you. I'll quickly answer that great question. So growing skull fractures, we tend to see a lot specifically in our infant group. We tend to monitor first for the first 3 months. Obviously, as many of you know, there's the fracture, but sometimes there's an underlying dural leak that perpetuates the condition. So you want to aim for hopefully a split graft cranioplasty. So you want to try get your children at the age where you can use their own bone. That is more economically cost effective in our environment than 3D molds that they might outgrow later. So it does mean we tend to monitor our patients a bit longer, and then once we get to the point where we can do that split graft cranioplasty and along with that dural repair, that is our preferred mode because it's cost effective and more sustainable than 3D molds. I hope that answers that. Thank you.
I want to thank everyone, especially Dr. Rock, who organizes this entire series of lectures. I want to thank Jeannie Bray, who does all the work. You know, let's admit it, this is where all the work is done, and we thank you very much. Dr. Thango, Dr. Tran, thank you for enlightening us today and bringing us together over around a very important topic. Thanks so much.
Thank you.
Thank you very
And
much.
just so that everyone knows, it will be in the next 2 to 3 days. This recording will be live on the FEENS website under the virtual visiting professors. So thank you again all for joining us today.
Thank you.
Thank you very much.
Thank you. Bye.
Bye.